All right, folks. Well, we're going to introduce our first uh, expert speaker, Dr. Hal Gerstein. We've known for, I don't know, maybe a couple of decades. And we're fortunate enough, Marianne is fortunate enough to have met him before she was diagnosed with a NET. But Dr. Gerstein, who has always claimed, at least in front of me, to not be an expert, for someone who's not an expert, he's pioneered the use of angiogenesis inhibitors, modifiers, all kinds of different treatments, and brought them to patients far ahead of their availability to the general public. He's an awesome doctor, and I can't wait to hear what he has to say. Please welcome Dr. Gerstein.
Thank you, Bob. I hope everybody can hear me, and it's a pleasure to be here with everybody this morning. Bob is right. I am not technically an expert on carcinoid or neuroendocrine tumors. However, my experience does date back a couple of decades. I first met Marianne about 30 years ago, and after she developed and was diagnosed with her neuroendocrine tumor, she came to me and said, "I want you to take care of me." And I said, like most doctors about 20 to 30 years ago, I said that I didn't really know too much about it. And she came to me and said, "You better learn." And I learned. And with the help of several mentors, including Richard Warner and Jerry Zaks in New York City, and other experts around the country, which I've been lucky enough to collaborate with, and many of whom you'll be hearing from today, I started learning a lot, and I developed a nice practice and a fair number of patients with neuroendocrine tumors here on Long Island. So from the cold north to everybody around the country, thank you for having me today. I've been tasked today to speak to you about an overview of neuroendocrine tumors, and I'll try to do that briefly in my allotted time. Okay. So neuroendocrine tumors are neoplasms. They are cancerous tissues that arise from the endocrine cells of the hormonal and nervous systems in the body. They most commonly occur in the intestine, where they're often called carcinoid tumors. However, they can also be found in the pancreas, lung, and the rest of the body. There are many kinds of neuroendocrine tumors, but we treat them as a group of tissues under one umbrella because these neoplasms share many common features. They look similar. They have special secretory granules that produce amines and polypeptide hormones that have some wide-ranging effects on our body. The discovery of neuroendocrine tumors dates back to 1870 when Rudolf Heidenhain discovered neuroendocrine cells, which can lead to the development of these tumors. Oberndorfer was the first to describe the term carcinoid in 1907 because he said that these cells look like carcinoma, hence carcinoid, although they didn't behave like a malignant carcinoma. Pancreatic islet cells were first described in 1869 by Paul Langerhans, and when I went to medical school, we called the pancreatic tumors islet cell tumors. The islet cell tumors that were responsible for hyperinsulinism or insulinomas were first described in 1924, and in 1942, glucagonomas were first described, also arising from the pancreatic islet cells that produce glucagon. And so on and so forth, we began to notice many other different types of neuroendocrine tumors, each producing different kinds of syndromes. Carcinoids which are the common term we use for neuroendocrine tumors that arise in the small bowel, particularly arise in the ileum, and very commonly in the appendix as well. Many carcinoid tumors of the small bowel are asymptomatic and discovered only incidentally during surgery for other causes. These coincidental carcinoids are quite common, and one study found that 1 person in 10 actually has them. Many of these tumors do not produce any symptoms at all, and hence they're very difficult to diagnose. Some tumors, even when they're very small, can produce adverse effects by secreting hormones. So the presentation, the signs and symptoms can be quite variable. And sometimes we don't discover these carcinoids, as you all may well know, until they've already metastasized. Some of the hormones that are produced by the gastrointestinal carcinoids, most notably is serotonin and other cytokines. These cytokines can produce a constellation of symptoms known as carcinoid syndrome. That could include flushing, diarrhea, asthma, congestive heart failure, abdominal cramping, even edema. This is just a schema of the carcinoid tumor and how complex it is as far as the metabolism and how we can attack these tumors and treat them. We'll talk a little bit more about this later. As I mentioned, the carcinoid tumors most notably occur in the gut, the foregut, midgut, hindgut, and of course the pancreatic neuroendocrine tumors known as PNETs. I'm going to briefly mention that this is an older slide, but it really hasn't changed all that much. The incidence of neuroendocrine tumors is rising faster than other malignancies. And this is perhaps because we're more aware of what's going on and we're making the diagnosis perhaps a little bit better, but it may be due to other conditions as well. The incidence is rising more rapidly in lung and small intestinal carcinoids as compared to other areas of the body. And we are getting better at identifying earlier stage carcinoid tumors or neuroendocrine tumors. And so as the years have progressed over the decades, we have been finding them earlier before they become regional or metastatic disease, and obviously that portends a better prognosis. In a bar graph, it shows that the localized carcinoids are more commonly identified now as compared to distant and regional spread. However, if you notice that the symptoms will not appear many times until there's already metastases. So during the primary tumor growth, the symptoms can be quite vague, nonspecific, and therefore difficult to diagnose. After the disease metastasizes, we begin to see the flushing, diarrhea, and other symptoms of carcinoid syndrome, and unfortunately that's at a later stage. So like all cancers, earlier diagnosis clearly portends a better prognosis. The WHO classification, which I'm sure Dr. Wolin will go into a little bit more detail, the prognosis is based on whether the tumor is well differentiated or poorly differentiated, whether there are metastases, whether there's a higher incidence of cell proliferation, which is the Ki-67 index, and whether there's angioinvasion, which is an invasion into the blood vessels, and of course the tumor size. So as you can see, these factors will play a part in the prognosis of our patients. Survival is associated with both tumor stage as well as tumor grade. So the earlier the stage and the less aggressive the tumor, survival is better. So to summarize this introduction, neuroendocrine tumors are malignancies. They arise in cells whose normal function is to secrete peptides or these hormonally vasoactive substances, although not all do. Advanced disease is associated with a worse prognosis, but even small tumors can become metastatic, and that's why tumor grade is also important. Okay, so how do we diagnose neuroendocrine tumors? I said that it's difficult to diagnose, and that's true. As a physician, we have to take into account the symptoms that the patient presents to us, what the patient complains about. We take into account any signs that we may find on physical examination, and of course, laboratory data. And laboratory data can be quite helpful, although it's not always helpful. Serotonin, chromogranin, neuron-specific enolase, pancreastatin, pancreatic polypeptide, all very important, as is the urinary 5-HIAA. For when we're looking at specific PNETs and some of the endocrine syndromes that pancreatic neuroendocrine tumors can manifest, we look for glucagon, gastrin, vasoactive polypeptide, etc. So laboratory testing can be quite important in firming up the diagnosis and also following our patients for treatment. As far as radiology, chest x-ray, sonogram, CT, I mentioned them. They're not all that great in making the diagnosis. The CAT scan is notoriously, in my opinion, insufficient in looking for radiographic evidence of neuroendocrine tumors. The MRI scan is much, much better. And of course, we use PET scans. FDG PET scans, the typical PET scan that we look for most tumors, lymphomas, breast cancers, etc., is not all that helpful unless we're dealing with a poorly differentiated neuroendocrine tumor. We are much more interested in getting a PET scan using some of the somatostatin analogs, octreoscan, and of course the newer one, gallium-68, which has by and large replaced the octreoscan. We use endoscopy for direct visualization, and of course biopsy and surgery, which is how we make the diagnosis. Once we make the diagnosis, how do we treat our patients? Cancer therapy for all cancers has become quite complex over the last few years. Traditionally, surgery is the number one step and still is for neuroendocrine tumors. Radiation therapy, external beam radiation, not so much used for neuroendocrine tumors. However, we will talk about a specific instance when we use a form of radiotherapy. Chemotherapy, again, not used as much for neuroendocrine tumors, although there is a place for it. Some of the newer treatment modalities, immunotherapy, it doesn't really have a place yet in neuroendocrine cancers, but perhaps Dr. Wallen will talk about that when he discusses some of the new and exciting new treatments that we have. What's my approach to neuroendocrine tumors? You know, it's neuroendocrine tumors is like fighting any cancer, and it's a war. We have to approach a tumor from all sides, from all fronts in a battle. And you know, I like to take a multiple approach to the tumors with surgery, with systemic therapy, with localized therapy, and treat my patients in such a way that we can effect the best outcome for our patients. So our modalities that we use in neuroendocrine tumors include, of course, surgery. It's still by and far the number one treatment for both diagnosis and restaging the patient and downstaging the patient and debulking the tumor. We also have used liver-directed embolization therapy. That's transarterial embolization, transarterial chemoembolization, and radioembolization using yttrium spheres. So this method is used to treat localized tumors in the liver, and especially those that have produced hormones and are symptomatic, and bring those tumors under control. As far as systemic therapy, we've used in the past interferon. Because of the toxicities of interferon and the difficulties with compliance in the patient, we don't use it as much anymore, but there still is a place. We've used hormone-directed therapies, especially to control symptoms. And I'm sure you're all familiar with the SSAs. That would be sandostatin and lanreotide. And those are really the foundation of systemic therapy in controlling the symptoms of neuroendocrine tumors. Recent studies have also shown that these therapies could also control and limit the growth of the tumors. So not only will they control your carcinoid syndrome symptoms, but also now limit the growth of the cancers. Telaretristat, which is better known as Zermelo, is a relatively new medication. It's an oral medication that will decrease the production of serotonin in the tumor cells and hence improve the symptoms of carcinoid syndrome, specifically the diarrhea. Telaretristat is always used in conjunction with the SSAs, either sandostatin or lanreotide, and does not replace it. Some of our newer methods of treatment include tumor-directed therapy. We've all been hearing a lot over the last few years about PRRT, using Lutathera, which is a radiotherapy, a type of treatment that targets the somatostatin receptors on the tumor cells. It can be quite effective. It does require multiple treatments and has in recent years moved up the ladder and is used earlier and earlier in our treatments for neuroendocrine tumors. We also use some targeted therapy using sunitinib or everolimus, specifically for PNETs, pancreatic neuroendocrine tumors. And we've also used cytotoxic chemotherapy, CAP10, which is capecitabine and Temodar, and that's an oral regimen for a gastrointestinal. This is just, I hope you all can hear me now. This is just a schema, an algorithm that had been used recently for treatment of neuroendocrine tumors. And as you can see, there are multiple pathways that we can take when we look for treatment for our patients. But on the bottom, we see the PRRT and that has clearly moved up in the algorithm. So this is going to need to be updated. So the big question is, how do we sequence? How do we combine our therapies? And this is becoming more and more controversial and always changing. So if you come across a doctor that looks like this guy, Borat from Kazakh, and he starts telling you that he knows everything there is to know about neuroendocrine tumors, you've really got to run away and find a collaboration of doctors that will work together and help plan the best treatment for you. one of the neuro modalities of treatment that I've been very interested in with all my cancer patients, not just neuroendocrine patients, is immuno-oncology regimens. I found that right now they're not that useful for neuroendocrine patients except those with high-grade or very aggressive malignancies. However, I think the future is going to hold a place for immuno-oncology in conjunction with targeted therapy and other modalities for our neuroendocrine patients. So is that all we've got? I don't think so. And one of the reasons that we like to work in a group for our patients with neuroendocrine cancer, and why even someone like myself, I will collaborate with other doctors, with our patients, to come up with new ideas and new methods of treatment for our patients. If everyone's thinking alike, then somebody isn't thinking. So get your opinions, speak to other doctors, and work with your doctors in getting the right treatment for you. I don't want to leave anybody with a sour taste in their mouth. People with cancer are definitely living longer. We are focusing on the quality of life in addition to the quantity of life. Sorry about that. And we want our patients that survive with cancer to live normal lives. That is particularly important for neuroendocrine patients because of the symptoms that you have. New treatments of various kinds are becoming available every single day. And we've all seen that over the last few years with all cancers and as with neuroendocrine patients as well. Don't let the cancer overwhelm you. Your symptoms can be controlled. Let us help you. Let your oncologist help you. Let the support staff help you. Let your families help you. You'll get over the symptoms. We'll control the cancer. And hopefully, you'll have a nice, long relationship with your oncologist, just like I've had with Mary Ann for 30 years. Thank you for your time. And I'll be around for any questions in the questions and answer session.